Thanks for joining today. I have lots of information to cover today, so I may talk a little fast, but if we get cut off or if you miss anything, like Marie said, the presentation and the slides will be available on vitalware.com. All right, so let's get started. So first we have our disclaimer statement, and this is just saying that at the time of this presentation, this information is current. This is just a general overview, and we do encourage you to review the guidelines and the regulations yourself as well. Okay, so on our agenda today, we have CM chapter-specific code additions, deletions, and revisions, CM guideline changes, PCS chapter-specific code additions, deletions, PCS guideline changes, and MS-DRG updates. Okay, so let's start with CM code changes. So in summary, for 2022, we have 159 new codes, we have 20 revisions, and 32 deletions. That brings our total codes up to 72,748. We have 71 new POA exempt codes, and we have 9 new MCCs, 2 deleted MCCs, 11 new CCs, and 1 deleted CC. This next slide is just showing you the tables for the new MCCs and CCs and the deletions. You see that for the deletions, those have actually been expanded upon in the addition tables. Next, let's look at the additions and deletions and the revisions. In the interest of time, I'm not gonna go through every single code and bore you to death with that, but I am gonna point out some important things having to do with the additions. I do list every code in here just for your reference so that you have something to come back and reference afterwards. So for chapter 1, certain infectious and parasitic diseases, we have 1 addition. You will also notice on the additions and deletions behind the code description, I included if they are a CC or MCC. For chapter 2, neoplasms, we have 3 new additions. And I want to make a note about the C84.7A. That's the anaplastic large cell lymphoma. This commonly occurs in patients with breast implants. However, the implant complication code from chapter 19 should not be assigned with this code. Chapter 3, diseases of the blood and blood forming organs and certain disorders involving the immune mechanism. We have 1 deletion here, and you'll notice that it's been expanded upon in the additions. Chapter 4, we have 1 addition. Chapter 5, mental, behavioral, and neurodevelopmental disorders, we have 1 deletion, and this has been expanded upon in the additions, and we have 3 additions. Sorry about that. All right, next slide, chapter 6, diseases of the nervous system. We have 1 deletion, and this has actually been expanded upon in the additions. If you look at in the additions at code 644.86, serogenic headache, there's just a note here that you also want to code the associated cervical spinal condition when it's documented. And then for the next code, the G92.00, immune effector cell associated neurotoxicity syndrome, there needs to be explicit documentation of the grade in order for you to pick up a grade. And it needs to be documented by the provider. If he does not document the grade, it needs to be coded to the unspecified code. And just take note that the underlying cause of the ICANS needs to be coded first. The revisions for chapter 6 are very minor. They misspelled the word unspecified, so they just corrected the spelling. For chapter 7, we have no changes. Chapter 8, we have no changes. Chapter 9, we have 1 addition, and that is the non-ischemic myocardial injury, non-traumatic. And just a note here, you want to make sure to code the underlying cause first. Chapter 10, we have no changes. Chapter 11, we have quite a bit of additions here. You see with the deletions, the K22.8 specified diseases of the esophagus. This has actually been expanded to the first few codes within the additions. The rest of the additions have to do with gastric intestinal metaplasia, and these have been expanded to include with and without dysplasia, and to capture specific body parts, multiple sites, and unspecified. Chapter 12, we have 8 new codes related to irritant contact dermatitis. Chapter 13, we have quite a few additions here. You'll see on the second code, M3 1.11, hematopoietic stem cell transplantation associated thrombotic microangiopathy. The transplant complication should always be coded first, and you should use the additional code for any specific organ dysfunction. The deletions here, the M3 1.1, this has been expanded to capture unspecified, and the M5 4.5, which is the low back pain, that has also been expanded to capture the unspecified. On the additions, the last few codes, the non-radiographic axial spondyloarthritis, I just wanted to mention that these were added just to capture the specific regions of the spine. So next slide is just a continuation of chapter 13. And then you'll see the revisions here. And all that they're changing here is the code description. They're changing it from Sika syndrome to Sjogren's syndrome. Chapter 14, we have no changes. Chapter 15, we have no changes. Chapter 16, we do have some additions here, and we do have one deletion, the P09. This has been expanded to be more specific within the additions. Chapter 17, we have no changes. Chapter 18, symptoms, signs, and abnormal clinical and laboratory findings, not elsewhere classified. We have 3 here. The R05 cough has been expanded to include different types of cough. The R35.8, other polyuria, has been expanded, and the R63.3, feeding difficulties, has also been expanded in the additions. I just want to turn your attention to the additions, the R05.1, acute cough. This is a cough that has been going on for less than 3 weeks. If it's between 3 and 8 weeks, you to the subacute cough code. And then if it's been going on for longer than 8 weeks, that's when you would put the chronic cough code. Next slide is chapter 19, injury and certain other consequences of external causes. Lots of additions here, mostly having to do with poisoning by cannabis. On this, at the top of the right-hand side, T80.82XS, I just wanted to, this is complication of immune effector cellular therapy. I just wanted to make an additional note here that an additional code to describe the specific complication should be assigned as well. Right under there, have your traumatic brain compression codes, and you always want to make sure to assign that underlying traumatic brain injury first. Chapter 19, we have more deletions, and this, you'll notice that these were just expanded upon in the additions. Still chapter 19 here, for revisions, all of these codes listed needed to have their title revised. Portuguese was misspelled, so they just corrected it. Chapter 20, we have 3 new additions. Chapter 21, on the deletions, on Z59.0, homelessness, this has been expanded in the additions. Z59.4, lack of adequate food and safe drinking water. This has actually been reworded to food insecurity, and it's also been expanded. Z59.8, other problems related to housing and economic circumstances. This has been expanded and reworded to housing. Z91.5, personal history of self-harm. This has been expanded and reworded to suicidal behavior. And then in the revisions, they just changed the word immunosuppression. That was misspelled. Chapter 22, codes for special purposes. They have a new code, U09.9, post-COVID-19 condition unspecified. You're going to see a lot about this code in the following slides. This code enables the establishment of a link with COVID-19, also called long haul COVID. This code is not to be used on active acute COVID cases. This is used when a patient has gotten over the active COVID infection and is still having a condition that was related to that infection. Okay, so now we're going to move on to the CM guideline changes. The first change is level of detail and coding. They just put to that when coding, you should always code to the highest level of specificity documented in the medical record. So you're going to see this quite a few times within the guidelines. And there was talk of CMS actually downgrading payment if in the future, if an MCC or a CC was coded to unspecified when a more specific code is available. There's no yet, but you'll notice that they mentioned that a few times within the guidelines that you need to code to the highest level of specificity. So it's always good to do that. Let's see. So on number 3, they just added the code range for the U codes. Number 13, laterality. So here they're talking about laterality documentation and that it can be taken from any clinician on the case. And that if there is a conflict between providers, then you should always query the attending to see what the correct laterality is. Okay, so next section, documentation by clinicians other than the patient's provider. So here they just clarified what they meant by clinicians, and they say in this context, clinicians other than the patient's provider refer to the healthcare professionals permitted based on regulatory or accreditation requirements or internal hospital policies to document in a patient's official medical record. And then the exceptions that are listed below, that is documentation that can be picked up from any clinician on the case. It does not have to be the attending provider. And the only difference here is that they took it out of a paragraph format and put it into a listing format in the guidelines because they keep adding to this list and just to keep it looking neat, basically. They did add the blood alcohol level to this list. And then the next paragraph is just talking about how it was added and that the provider should always be the one that documents the alcohol-related disorder and that the blood alcohol level can be taken from another clinician. All right, so next section. Here they, on number 18, use of sign, symptom, and unspecified. Here they're just highlighting the importance of specificity once again, and that it's a joint effort between the coder and the doctor to get accurate coding. Number 19, coding for healthcare encounters in hurricane aftermath and the use of Z codes. Here they're just saying that added the statement or provide additional information relevant to a patient encounter as a reason why a Z code could be used. Okay, next slide. Here we are talking about the selection and sequencing of HIV codes. And in this paragraph, they just added the HIV disease along with the AIDS. In this statement, code Z21, asymptomatic HIV infection status, should not be used when the terms AIDS or HIV disease are documented. And that's what they're saying here. The second paragraph, paragraph H, they just added if applicable. And then paragraph I, here they're just saying that if a patient with a documented history of HIV is being managed by antiretroviral medications, you would assign B20 with Z79.899 long-term current use of antiretroviral medication. So next slide, we are moving on to COVID, and they just added guidance here on where to find guidance on COVID related to certain conditions, like within COVID related sepsis or COVID in pregnancy, etc. So next section, staying with COVID here, they added the expanded codes here. They added the R051, the acute cough, and the R059, the cough unspecified here. The next paragraph, it gives guidance on follow-up visits related to a previous COVID condition. So Z09 and Z86.6 are used if there are no lingering conditions, but if there are lingering symptoms or conditions related to that active COVID infection, then they say to see other guidance. They tell you where to see the guidance. because that code is not appropriate in that case. And then next paragraph is the multi-system inflammatory syndrome. If an individual with a history of COVID-19 develops MIS, you should assign codes M35.81 and U09.9. You should not assign a personal history of COVID code in this circumstance because the patient is having an associated lingering condition. All right, next slide, sticking with the COVID here. The first paragraph is about the post-COVID-19 condition, which is that new code that was added. And they're just saying that post-COVID conditions use U09.9 post-COVID condition should not be used for active COVID case. And then the next paragraph is probably a rare circumstance, but it's basically saying that if a patient has a past history of COVID with a condition and then develops a new active COVID infection, then both should be used for the active COVID condition and the post-COVID condition. And then any manifestations should also be assigned. Next slide, we've covered this already, but this is the breast implant associated anaplastic large cell lymphoma. And they're just saying that you should not assign a complication code from chapter 19 for this. Next slide, talking about diabetes. The main thing here is that if a diabetic patient is treated with both oral medications and insulin, then both Z79.4 long-term current use of insulin and code Z79.84 long-term current use of oral hypoglycemic drugs should be assigned. And then the next section is the exact same guideline, it's just for secondary diabetes. Next section is on mental, behavioral, and neurodevelopmental disorders. And the first paragraph is just minor wording changes. The second paragraph is stating that medical conditions due to substance use, abuse, and dependence are not classified as substance-induced disorders. Assign the diagnosis code for the medical condition as directed by the index, along with the appropriate psychoactive substance use, abuse, or dependence code. And then they give you an example here. The next section is on blood alcohol level. And this is related to the documentation. And again, just saying that the associated condition from the alcohol-related condition should be documented by the provider, but that the actual blood alcohol level came from another clinician's documentation. All right, next slide, ventilator-associated pneumonia. So this is just giving you guidance on where to find pneumonia confirmed as due to COVID-19. The next chapter, we're talking about unstageable pressure ulcers, and this is just saying that if a stage of an unstageable pressure ulcer is revealed after they do a debridement, then you would only assign the code for the stage that was revealed following the debridement. All right, next slide. So under chapter 15, the pregnancy, childbirth, and puerperium, the final character for trimester. So here they're just saying that if there is a code with a description of in childbirth, this should be used. But if there's no option for the associated condition that has that verbiage in childbirth, then you would just code the appropriate trimester that the patient's in. So the next several sections are all having to do with the pregnancy section, chapter 15, and they basically just changed all the wording of mother and women to patient, just to be more inclusive. So I'm going to just kind of skip through these. Next chapter is, let's see, chapter 18, symptoms, signs, and abnormal clinical and laboratory findings. And here they're talking about coma code R40.20. And they're just letting you know that this code can be assigned with any medical condition, but it cannot be assigned when the coma was medically induced or the patient was sedated. And then they added the coma scale codes. They added to those, you'll see. And then they just say that if the coma scores are captured within the first 24 hours after hospital admission, then you would only assign the code at the time for the score at the time of admission. The classification does not it doesn't classify coma scores that were reported after admission, but less than 24 hours. All right, so chapter 19, injury, poisoning, and certain other consequences of external causes. Here we're talking about coding of burns and corrosions, and they're just clarifying in this paragraph that these codes in category T31 should only be used for acute burns and corrosions. All right, chapter 21, factors influencing health status and contact with health services. First, we have the history of codes, and they just wanted to remind everyone that the reason for the encounter should always be sequenced first, then the history code. In the donor paragraph, that they just have wording as well as added here. Number 10, counseling. This is specifically, this code, the Z71.85, should only be assigned if the patient specifically comes in for immunization safety counseling. This should not be assigned if the patient comes in for administration of an immunization and they are just given general information about that vaccine. This is if they're like specifically coming in to be counseled about the safety of that vaccine. And then number 14, miscellaneous Z codes, they just have a wording change here. All right, and then number 17, social determinants of health. Just saying that social determinants of health codes should always be coded if they're documented, and that they can from any clinician. It does not have to be the attending provider. It can be a social worker, a case manager, etc. And then next, chapter 22, codes for special purposes. These are your U codes. We have a couple new ones, the U07.0, which is the vaping related disorder. And then of course, we've seen this one, the U09.9, which is the post-COVID condition. Next, we're going to move on to outpatient guideline changes, and there's not many changes to outpatient guidelines. So they added the U codes here, and then for the coding, they're again highlighting the importance of the specificity of coding. And then I just wanted to share that effective April 1st, 2022, ICD-10-CM PCS updates will occur on April 1st of each year, in addition to the October 1st update. It's going to be the same process that's used for the code releases. CMS is recommending a phased approach with limited April code updates. So keep an eye out for that change. They should be providing more information. Next, we're going to move on to PCS changes. And for PCS, we have 191 new codes, and the majority of these new codes are in the medical surgical section and the new technology section. We have 107 deleted codes and 62 revised titles. That brings us to a total of 78,220 PCS codes. So we're gonna jump into the tables here, and you'll notice that on each table, the underlined words are actually the additions to that table. So I'm going to tell you a little bit about why these additions were made and what the codes can be used for. So this first table, 00D, the extraction of central nervous system and cranial nerves, this change was made to identify procedures such as a microsurgical hemispherotomy performed using a Cavitron ultrasonic surgical aspiration. The table 02C is the extirpation of heart and great vessels. This change creates replacement codes in the med-surg section for codes that were deleted as a result of updating section X group 1 codes. Table 02F, fragmentation of heart and great vessels. This change was made to identify coronary intravascular lithotripsy. Table 02R is the replacement of the heart and great vessels. This first table, you'll see the addition of the heart as the body part and then a new device there. This identifies implantation of auto-regulated electrohydraulic total artificial heart system. And an example of this would be SynCardia. The table directly under it identifies implantation of a total artificial system that has external pneumatic drivers. An example of this would be the Carmat total artificial heart system. And then the last table here, this allows distinguishing transcatheter replacement of the pulmonary valve at an existing conduit versus a native site. So next table, O2V. This is restriction of the heart and great vessels. These codes will allow identification of procedures such as the placement of the Ancora AccuCinch device. O31 table, bypass of the upper arteries. These codes, the approach of percutaneous was added, and this is now going to allow identification of procedures such as the creation of an arteriovenous fistula by connecting the brachial artery to the lower arm vein, such as when using the ellipses vascular access system. All right, and then table O3F, fragmentation of the upper arteries. This will allow identification of procedures such as a clot maceration performed in a cerebral artery using a microcatheter. Table O6L is the occlusion of lower veins. This is going to be used for procedures such as the endoscopic banding of the hemorrhoidal plexus. O6L continued right here. And then O7D, extraction of the lymphatic and hemic systems. You can see that bone marrow has been added to the body parts, and this is going to be used when the bone marrow is extracted from other sites such as the femur. All right, table OF8, this is the division let's see, of the hepatobiliary system, and this allows for reporting of associated liver partition and portal vein ligation for stage hepatectomy, otherwise called ALPPS. The next table is OK8, and this is the division of muscles. These procedure codes will allow us to report procedures such as the stapling of Zinker's diverticulum via a transorifice or transorifice endoscopic approach. Next table is ONH, and this is the insertion into the head and facial bones. You can see that infusion device was added as a device here, and these codes will identify procedures such as the implantation of an Ommaya reservoir for the intracranial administration of chemo. Next table is the reposition of the upper bones. And you can see that they added the device, spinal stabilization device, vertebral body tether. The addition of this device is for codes that treat progressive idiopathic scoliosis. Next table is OQB, the excision of the lower bones. And these procedure codes will help us to identify procedures such as the excision of fibular or tibial sesamoid bones. You can see that the qualifier that was added is the sesamoid bone. And then the next table is OQS, reposition of lower bones. You can see this is again the spinal stabilization device, vertebral body tether. The only difference with this one is that it's on the body part lumbar vertebrae. So this is just a different part of the spine. And next table is ORP, removal of the upper joints. This slide and the next one, tables ORP and ORW, they have 28 new procedure codes that identify the removal and revision of components of a partial shoulder arthroplasty. And here's the revision codes. And next is table 302, and this is transfusion into the circulatory system. You'll see that the fibrinogen complex was added as a substance. One thing I wanted to mention here on this table is that for the approach, open was actually deleted as an approach here. So for the body systems, peripheral vein and central vein, open approach is no longer an option because it's considered clinically invalid for these to be labeled anything but percutaneous. So that resulted in the deletion of 87 codes. Next table is 3E1, irrigation of physiological systems and anatomical regions. And they added an approach here of percutaneous endoscopic. This identifies laparoscopic irrigation of the peritoneal cavity for therapeutic or diagnostic purposes. Table 4B, measurement of physiological devices. This is a new code for cerebrospinal fluid shunt measurement using a wireless sensor. An example of this would be the use of a FlowSense, which is a wireless non-invasive thermal flow sensor. Next table is 5A1, performance of physiological systems. And you can see that they added the qualifier of automated here. And this is for devices that deliver automated mechanical chest compressions. Table BF1 is next, and this is fluoroscopy of hepatobiliary system and pancreas. And these new procedure codes will allow for the reporting of fluoroscopic guidance used with procedures such as the drainage of a liver abscess. X2C is extirpation of the cardiovascular system. This is in the new technology section, and lots of body parts added, and also a device and qualifier. And these were created to identify extirpation of matter from arterial and venous systems using a computer-aided mechanical thrombectomy aspiration device. And this is used to treat occlusions in non-coronary or non-intracranial artery or vein, or in an arterial bypass graft. Next table is X2J. It's the inspection of the cardiovascular system. And we have one new code here, and it would be used to identify the utilization of software to guide transthoracic echocardiographic image acquisition. And just a note here that the transthoracic echocardiography can be separately reported using the appropriate code from section B in imaging. Next table is X2K, and it's the bypass of the cardiovascular system. And these two codes were created for the identification of percutaneous creation of an arteriovenous fistula using thermal resistance energy. An example of this would be using the ellipses system. The next table is X2R, the replacement in the cardiovascular system. This code that's listed should be used in conjunction with a code X2VWON7, the restriction of the thoracic aorta. And I'm going to talk more about this on the next slide. So before I go into that, we're looking at table X2V, restricted cardiovascular system. The first table describes the insertion of a reduction device in the coronary sinus for refractory angina. The second table is, this code is actually used for a procedure using a dual purpose medical device. An example of that is the Thoraflex hybrid device, and that it replaces the ascending aorta and the aortic arch while also stabilizing and repairing the descending thoracic aorta in a single procedure. Both the replacement code that was listed on the previous slide and this restriction code should be used together when this procedure is performed. Next table is XD2, and this is the monitoring of the GI system. And they added the oxygen saturation to the device substance technology section. And this is just to describe tissue oxygenation during surgery. The table XDP is irrigation of the GI system, and this just identifies intraoperative colon irrigation performed with a disposable oversleeve. Next table is XFJ, and this is inspection of the hepatobiliary system and pancreas, and these procedure codes will be used to identify use duodenoscope for endoscopic pancreaticobiliary system procedure. The next table is XHR, and that is the replacement of skin, subcutaneous tissue, fascia, and breast. And this was created for the replacement of skin using bioengineered allogenic construct for treatment of adults with severe thermal burns, but still having some intact dermal elements. Next table is XNS, and that is the reposition of bones. And this identifies the utilization of a posterior dynamic distraction device in procedures to treat patients with adolescent idiopathic scoliosis. Just a note here that the applicable ICD-10-PCS code from the table ORG, fusion of upper joints, or OSG, fusion of lower joints, should also be assigned for this procedure if any spinal fusion is performed at the non-instrumental segment of the vertebrae. Next table is XRJ, and this is fusion of the joints. There are 12 new codes that describe the use of a patient-specific customizable invertebral body fusion device for the correction of adult spinal deformity. Excuse me. Next table is XWO, introduction into the anatomical regions. The first table here that you'll see is 8 new substance values, and all of these substances will have a qualifier 7 and a new technology group 7. Next table is the CAR T-cell therapy. There has been some changes to the CAR T-cell therapy tables because to resolve a conflict, because the CAR T-cell therapies were being classified into 2 different tables previously. So now all CAR T-cell therapies are classified into a single root operation in table XW0. And then you'll also notice that autologous has been added. I'm sorry, I didn't move slides. So on this slide, this is table X, still on the same table that we were on previously. The first table is 4 new product-specific substance values created for existing products. The second table is 2 new product-specific substances values that were created for new products. And these are both for the treatment of multiple myeloma. The last table here is adding an antibiotic-eluting bone filler. This is implantable and it's intended to fill a space remaining after a bone excision or a bone debridement and to elute antibiotics. The next table is XW1. And this is introduction into the anatomical regions, new technology section. And these new codes will allow for the administration of IV administration with these substances to enable efficient tracking when used for the treatment of COVID-19. Next table is XWH, and this is into the anatomical regions. And you'll see that the neurostimulator lead was added as a device. This identifies the use of electrical pulses to stimulate sensory nerves in the oropharynx used to treat neurogenic dysphagia in adult patients with a tracheostomy when they are weaned from mechanical ventilation. Next slide is table XXE, and it is measurement of the physiological systems. Lots of information on this slide, so I'm gonna try to get through it. Let's see. So the first code here, the measurement of intracranial vascular activity. This identifies the use of software that characterizes Alberta Stroke Program Early CT score, which is also known as ASPECTS. Using computed tomography image data. The second code here for the measurement of pulmonary artery flow, this also identifies the software analysis of a CTPA with computer-aided triage and notification software, and this is used to detect pulmonary embolism. Just a note about these first 2 codes. When using these 2 codes, these are actually for the software that's used. So you would also want to assign the imaging code from section B imaging. The last 3 you see are used to identify each component detection of antibodies from blood and nasal specimen to detect the cause of an ischemic stroke or a COVID-19 infection status. The next table is XY0, and that's going to be our last table for today. And you can see that they added the anticoagulant here under the device section. And just a note about this, you want to continue to report the renal replacement therapy using the appropriate code from table 5A1 when using this new procedure code. Okay, so now I have several slides of deleted PCS codes and potential replacement codes. So I just have this here for you as a reference so that if you aren't sure what to replace one of these deleted codes with, you have it here. I'm just going to go through these. And now we're going to look at some revisions to PCS codes. There's only one table that had revisions, and it's the introduction to physiological systems and anatomical regions. They have 62 revisions in this section, and it's the same revision on all 62 codes. It's just the addition of the word anti-neoplastic in front of the monoclonal antibody. So next we have a few PCS guideline changes. Here they just added specific in front of the root operations to make it a little more specific. The next paragraph is there was confusion about the root operation control and when to use that when referring to controlling hemostasis. So they clarified that if you have to control hemostasis beyond typical measures during surgery, that's when you would assign another code with the root operation control. You would not want to use it if it's just the typical integral part of the procedure. Next guideline change, under body part here, if a procedure is performed on a continuous section of a tubular body part, code the body part corresponding to the furthest anatomical point of entry. So they took that out because there was confusion with that statement, and they changed it to the anatomically most proximal, closest to the heart portion of the tubular body part. They also expanded on the example to just really try to make this clear. This next section, they added insertion as an operation here while talking about the GI body system and operations that can be used. And then there was a slight change to the new technology section. They just revised the example. They wanted to use a different example. All right, so now we're going to go over MS-DRG changes on version 39. And I'm sure most of you know this, but I just wanted to share, for in case you don't, that these changes moving procedure codes from one MS-DRG to another, these happen because of data analysis, and when they see variation between cost, length of stay, and volume between cases in the same DRG, that's what causes them to move it to a different DRG, because the thought is that procedures within the same DRG should use the same amount of resources, should be the same, similar cost, length of stay, and volume. So this is a table that comes from CMS, and I have the link here if you'd like to go find it. This is a really good exercise to see how case mix index and reimbursement may be affected for your facility in the upcoming year. So all you have to do is take your top 20 MS-DRGs by volume at your facility, and then you compare this chart from last year to the upcoming year. And this chart actually shows you what the weights of the DRGs are. So you look at just those 20, and you can see if the weight changes. You can see if you'll be positively or negatively impact case mix index wise or reimbursement wise. And a lot of times this is really useful information for your finance, reimbursement, and revenue cycle leadership, as well as administration. Okay, so next we're going to talk about pre-MDC MS-DRG 018. This is for the CAR T-cell therapy, and they added to this to include other immunotherapies. And then these codes listed below, they classified the following new procedure codes as non-OR procedures affecting this DRG. All right, so MDC-01, this is diseases and disorders of the nervous system. They added 3 procedure codes describing bleeding in the cranial cavity, and they added those to this MDC-01 in multiple DRGs. They also moved these 3 procedures, extensive OR procedure, unrelated to principal diagnosis, to non-extensive. And remember that these DRGs are only cases where the procedure codes are not related to the principal diagnosis. MDC-03, diseases and disorders of the ear, nose, mouth, and throat. So here they reassigned 3 procedure codes to describe the excision of subcutaneous tissue of chest, back, or abdomen, from major head and neck procedures to other ear, nose, mouth, and throat OR procedures. And same thing here, they moved those procedure codes from extensive OR to non-extensive when they fall into the DRG where the principal diagnosis is not related to the procedure. And then, let's see, MDC-04, diseases and disorders of the respiratory system. So
Can anybody hear me? Thank you. Yep, we'll just give it just another minute. Hopefully she can jump back on. Thank you.
hello, I'm so sorry.
No worries.
I'm so sorry. I don't know what happened. I think my internet got disconnected because it's like storming here.
Gotcha.
I'm going to continue. Hopefully most of that was recorded. But I'll start on MDC-05 here. Let's see. So they move these procedure codes that describe.
Hey, Mickey,
yes?
Sorry, do you want to pull your slides back up?
Okay, can y'all not see them? Let's see. Oh, that's why. All right. Sorry about that, guys. All
No
right,
worries.
so MDC-05, diseases and disorders of the circulatory system. So they moved these 3 procedures that describe the intraoperative insertion of a short-term external heart assist device They moved from DRG 215 to multiple more specific DRGs within, staying within MDC 05. And then code B 33.24 from MDC 18, that it was currently, well, it used to be in the DRGs for viral illness with and without MCC. It was moved to MDC 05 for other circulatory system diagnoses. And then they looked at a review of procedure codes in MS-DRGs 981 through 983 and 987 through 989. And one procedure code, drainage of urethra open approach, was actually moved from extensive to non-extensive. So the next slide is just showing, listed out here, all of the procedures that have been moved from non-OR procedures to OR procedures. And same thing with this slide. So all of these have been moved from non-OR procedures to OR procedures. And then this slide is showing all procedures that are moving from OR procedures to non-OR procedures. And that's all I have for today, but I just wanted to take a minute and introduce Vitalware at Health Catalyst. Here are some of the products that we offer. We offer products to help make facilities' revenue cycle processes more efficient. We work very hard for our clients to help them succeed, and we take great effort in staying up to date with our content and staying updated with everything on the newest rules and regulations, and making sure that our clients are staying up to date as well. You can find out more at vitalware.com. And that's it. Thank you.
Thanks. It looks like we have a few minutes for a couple questions, Mickey, if you're okay with that.
Okay.
Okay, so first one, I am wondering what the guidance is for choosing acute, subacute, and chronic cough. Are there specific lengths of time for each cough code?
There is. So we, that is actually in the slide deck. Let's see if I can get back to it here. I cannot recall off the top of my head, unfortunately. Let's see. That was in the addition section. Okay, so acute is less than 3 weeks, subacute is 3 to 8 weeks, and chronic is over 8 weeks.
Awesome. Next question, what is considered non-suicidal self-harm?
What is considered non-suicidal self-harm? That to me would be hurting yourself, but not the intention to actually kill yourself.
Great. Where can we locate a reference to the timing, in parentheses, number of days or weeks of the cough to identify acute, subacute, and chronic, which looks like we're on this one right here.
Yes, so they want to know the reference for this?
Yes, a reference to the timing.
Okay, so this was actually found, this I actually got from a presentation done by the American Health Association. I actually have the link in my references.
Let's see. Does this mean we'll have to get new books twice a year?
That is something I'm not sure about. It sounds like the April update is going to be very minimal. So I'm not sure if it'd probably be the kind of thing where you could probably just kind of write it in your book just to make a note of it, and you don't need to actually buy a new book twice a year.
Great. Do you have a link to the official notification about the biannual ICD-10?
Oh, let's see. That was actually came from the American Health Association as well. If you look in my references.
Perfect. Let's see. One more question that I can see right now. Able to code blood alcohol level from lab report, nursing note. Nursing note, yes. Has to be documented. Okay. I think that's all of the questions that we actually have right now.
Okay.
If you have any questions, you can always email us, but thank you everyone for attending our presentation today. Sorry about the cutout.
Yes, thank
This
you.
happens with technology.
Yeah.
And by the end of day today, you'll be sent the CUs and the link to the slides and the recording for this presentation. And we hope everyone has a great day. Thank you so much.
Thanks. Bye.
Bye.